Uh, Primary immune deficiency disorders. The first lecture is an introduction to what is meant by primary immune deficiency, why we should consider this diagnosis, to be followed by a series of lectures in which we are going to discuss one by one the different categories of primary immune deficiency. So let us start with the introduction. Immunodeficiency can be classified as primary, secondary, and physiological. Physiological, which is an expected kind of immune deficiency, is seen at the extremes of age and during pregnancy. In the very young, when the whole immune system is not fully developed yet, in the old, when there is waning of the immune system, and in the pregnant women, where it's a physiological suppression of the immune system so that the mother doesn't reject her foreign graft, which is the baby, and resulting in abortion. Secondary immune deficiency is secondary to disorders like some diseases, like nephrotic syndrome, like the administration of some medicine, like immunosuppressive agents, corticosteroids, patients with malignancies, patients with protein energy malnutrition. This is what we call secondary immune deficiency. We do not mean these two groups. We mean to study the monogenic disorders resulting in immune deficiency. Those are the physiological deficiency. Before going into more details about primary immune deficiency, of course, the hallmark of those disorders is the recurrence of infections. But when I speak about recurrent infections, I do not mean the recurrent occasional cold or occasional sickness that we all suffer from, and in particular the children do suffer from. Maybe even they could suffer from a minor illness like once every few weeks, once in a month. This is not what will cause me to worry about immune deficiency. Also, when infection is always recurring at one anatomical site, that will not raise my suspicion for immune deficiency. Like if somebody is always sick with suppurative tonsillitis, this is not an immune deficiency. If somebody is always having a urinary tract infection, I might rather look at a local anatomical problem leading or some etiology, a stone or something that predisposes this particular person for recurrence of the infection at one anatomic site. But this is not the immune system in general that will be the one implicated. PIDs, or primary immune deficiency disorders, are then considered monogenic inborn errors of the immune system. Initially, they were classified as rare diseases, but nowadays we have realized that they are no longer rare. They are quite common. The frequency might go very high in a certain condition. There are disorders, monogenic disorders, affecting cells, cytokines, organs, or hematopoietic and non-hematopoietic components as well can be affected. How many genes? We have at least 350 different genes implicated in different PIDs, and they can result in more than 350 related diseases because some genes may have more than one presentation. The hallmark, as I told you, is vulnerability to infections, but those infections are recurrent and commonly they are life-threatening. Sometimes also there is an association of other illnesses with infections like allergy, like autoinflammation, like autoimmunity, and malignancy. Early recognition of primary immune deficiency and the correct diagnosis is of utmost importance. many patients go on undiagnosed for quite a length of time. They become sick, they take an antibiotic, they are cured, and they become sick again, they take an antibiotic, and they heal, and it takes long years before starting to realize that really something is wrong. That's why we are trying to increase the awareness of people about the concept of primary immune deficiency, the importance to consider it when we are going to face those patients, not to leave them until they have permanent damage in their organs before starting to consider. Why is it important that we diagnose them early? Initially, it was thought that primary immune deficiency is an extremely rare disease. It's a very severe disease that usually causes death. So why really to worry and to spend time considering that? And there is no treatment. The patient will die anyway. This is completely wrong. Now we have a long list of life-saving treatments that have been developed specifically for those patients. There is a number of very useful antibiotics. In some situations, we can use the antibiotics even prophylactically, like we can give them even if the patient doesn't have infection to prevent the occurrence of infection in certain disorders. There is the availability of immunoglobulin replacement, whether by the intravenous route or via the subcutaneous route. There is a variety of hematopoietic stem cell transplantation, different kinds that can be applied to different patients that need complete cure of the patient. Gene therapy is booming now, and many disorders are candidates to be treated by gene therapy. There are other pharmacological agents being developed like monoclonals and enzyme replacement therapy. So if I have so many options, why not to give the patient the best chance of achieving control or sometimes cure of a very severe disorder? Immunoglobulin replacement therapy for the management of primary immune deficiency is something that should never be denied to those patients who require it. It is now on the WHO list of essential medicines. It's an effective life-saving treatment for many primary immune deficiency patients. It is cost-saving because it will spare the patient the trouble of going into hospitalization for several weeks and months for receiving very expensive antibiotics and leading to an unnecessary morbidity. It should be made available to all primary immune deficiency patients who require it. There are several IgG products. There are more than one way of administering, whether intravenous or subcutaneous, pump, without pump. All products should be available to all patients to suit the situation, because it can be better for one to use one line or the other, and the national health system should cover such treatments. The use of hematopoietic stem cell transplantation to replace the defect in the patient and lead to complete cure is now available for many of the PID patients. It has demonstrated good success, but the crucial point in the success in hematopoietic stem cell transplantation is when it is applied rather early, before the institution of severe infections. And in order to achieve that, how am I going to recognize the patient before the appearance of infections? So for the severe forms, the SCID, the severe combined immune deficiency, the way to do it is to do a neonatal screening, mass neonatal screening for all neonates in the country in order to pick up those with possibility of SCID, and then confirm the diagnosis so that they are given the chance of being transplanted early, before the appearance of infections, before administration of live vaccines that in themselves can result in infection in those patients. Gene therapy is now available for many primary immune deficiency diseases. It is available for some of the SCID patients. It is available for adenosine deaminase deficiency. It is available for Wiskott-Aldrich syndrome. It is available for leukocyte adhesion defect, and the list is growing. International collaboration and networking did promote the recognition of more and more primary immune deficiencies. It helped the progression of knowledge about more genes, about how the immune system functions, about creating new medicines. The need to coordinate with specialists all over the world, the need to register patients in international registries, the need to follow established guidelines really helps pushing forwards the progress in that field. This is the natural course of a patient with immune deficiency. The moment he is born, he is asymptomatic. He looks like a normal baby. He will spend some time being asymptomatic until he starts to get his infections or the early signs related to his PID disorder. And initially he will be diagnosed like any other disease. And then he improves but recurs and improves and recurs until he becomes really sick all the time. At that time, maybe they will start looking for the possibility of immune deficiency, and sometimes it is even postponed until late consequences appear. And if we start diagnosing the patient when sequelae are there, you are very close to death, and probably you cannot revert the damage that has happened. Our aim is to diagnose the patient sometimes as soon as he starts to get the symptoms. Even better if we diagnose him in the asymptomatic period, and this can be done like we do it here in this country, by focused screening in the presence of a positive family history. Like when I have a family who already had a SCID patient or more, the next baby that is born can be screened at birth for the possibility of being a SCID patient, ruling it out or diagnosing it early. We can also institute mass neonatal screening for all neonates, and when we know that this family carries the risk for immune deficiency, and when this defect is genetically diagnosed, molecular diagnosis, prenatal diagnosis is a possibility and is now carried on in Egypt. Primary immune deficiencies are classified into 8 groups. The latest classification includes a 9th group, which I will not speak about it. I will stick to the older classification with 8 groups. The 8 groups include predominant humoral deficiencies, predominant antibody deficiencies. The second is combined T and B cell deficiencies, the SCID patients. Then the third is combined immune deficiencies with syndromic manifestations, so the well-defined immune deficiency syndromes like Wiskott-Aldrich, Zizek-Higashi. The fourth is congenital defects of phagocytes. The defect could be in number or in function. There is the complement deficiencies. The sixth group is the immune dysregulation disorders. The seventh are the autoinflammatory disorders. And finally, the defects in the immune system, the innate immune system. How do we suspect PID in everyday practice? The hallmark of PID is the infections. And the commonest site of infections in the primary immune deficiency patients is commonly the respiratory tract infections, the sinopulmonary infections. Antibody deficiencies usually present as sinopulmonary infections, whether otitis, sinusitis, pneumonias. But together with the infections, when we find a child or an infant with recurrent serious infections, some people might think that it is so difficult to diagnose primary immune deficiency. This is not true. Just two very simple tests can help to suspect that yes, there could be a problem. Those two simple tests is a simple hemogram, but you have to read it thoroughly and to go through the differential leukocytic count in association with quantitation of the serum immunoglobulins. But again, take care that when interpreting the serum immunoglobulin concentration, you have to consider the age of the patient and the normal for age. Those two simple tests should be recommended as a screening tool for primary immune deficiency in a primary care setting. It has been developed some warning signs addressed to the public, to the general practitioners and nurses in order to be able to pick up those children with possible immune deficiencies. And these are called the 10 warning signs for PID. They include that the patient develops frequent ear infections in a single year. He must have at least two of the warning signs simultaneously so that we can suspect him as a PID. There is recurrent draining ears, recurrent serious sinus infection, recurrent pneumonias, recurrent deep-seated infections like sepsis, meningitis, or cellulitis, profound failure to thrive, recurrent deep organ abscesses or deep skin abscesses, persistent oral thrush beyond the first year of life. If the patient, every time he develops an infection, requires a long duration on antibiotics in order to clear his infection, 2 months or more, if he needs all the time intravenous antibiotics in order to clear infections, and one of the most important 10 warning signs is the presence of a family history, a positive family history, a family history of previously affected children. These are the same 10 warning signs, but present in a cartoon. There are 10 warning signs for adult PID because yes, there is an adult PID. You can diagnose primary immune deficiency for the first time in someone who is 20 years old, 30 years old, 70 years old, yes. Primary immune deficiency and early detection is important. Is important because effective therapy is available, because therapy is most beneficial when instituted early before the occurrence of organ damage, and because early detection and precise genetic diagnosis will help the family to plan for future reproductive options and allow for prenatal diagnosis. How do we suspect PID? We suspect PID sometimes by the syndromic appearance, like if we have a child who has partial albinism, large liver and spleen lymphadenopathy, and cytopenias, we suspect Shinya Kagashi. If you find a patient who is ataxic and having telangiectasia and recurrent infections, I suspect ataxic telangiectasia, and so on. But these are the rarities. The more common is that it's infections. But what kind of infections that will lead to suspecting primary immune deficiency? We call it the spur infections. The serious infections, persistent infections, unusual in site, unusual in severity, unusual in the type of organism, or R, and R stands for recurrent infections and runs in the family. The type of infection may predict the type of primary immune deficiency. So according what kind of organism are always responsible for the infection in this particular child or infant, so if it is mainly intracellular organism, and by intracellular organism I mean all viri, fungi, mycobacteria, brucella, salmonella, and pneumocystis jirovecii or carinii. This kind of infection dictates that probably I'm dealing with a T-cell defect. So it's going to be a SCID or a combined immune deficiency. Whereas if the main kind of infection is extracellular capsulated organism, because the capsulated organism require antibody and complement in order to opsonize this capsule, making it visible for the immune system. So if the infections are usually with extracellular capsulated microorganisms, I should suspect that the problem lies in antibody production, in complement deficiency, or in phagocytic disorders. Those are the extracellular bacteria and the intracellular bacteria. These are all intracellular organisms, and those are the capsulated. So, the kind of organism helps in diagnosing PID. As I just told you, if there is a defect in opsonization, which help phagocytosis, and we have cyanopulmonary infections, basically with capsulated extracellular bacteria, I should suspect gamma globulinemia or specific antibody deficiency or complement deficiency or a problem in the phagocytes, whether neutropenia or granulocytic defect. Whereas, and these are the predominant infections in antibody deficiencies I have just mentioned. Whereas if the infections are mainly intracellular slow-growing pathogens, I should suspect T lymphocytes or macrophages. In granulocyte defects, the age of onset is going to be variable. The first encounter with the first skin, with the first barriers, mainly the skin and then the draining lymph nodes, are the common sites of infection. So in granulocyte disorders, we commonly have skin infections and separative lymphadenitis. We have infections in the oral cavity, It can be associated with internal organ abscesses, osteomyelitis, and in certain disorders there is delayed falling of the umbilical stump, like in leukocyte adhesion defect. There is also the last group, which is a new group of primary immune deficiencies, where the patient has susceptibility for only one type of microorganisms, like the Mendelian susceptibility for a single infectious agent. For example, there is Mendelian susceptibility for mycobacterial tuberculosis. There is a Mendelian susceptibility for invasive herpes simplex, and when I speak about invasive herpes simplex, I do not mean oral ulcers, but I mean CNS invasion. Mendelian susceptibility of invasive strep pneumoniae and chronic mucocutaneous candidiasis. I will show you how does it look like. A patient who tends to have severe persistent fungal infections beyond the first year of life, persistent oral thrush, persistent skin affection, persistent nail affection. When we want to evaluate for immune competence, the most important part is the history and the family history and the general physical examination. Those will lead in a strong suspicion of a given form of immune deficiency in most of the time. And then we need initial labs, as we just mentioned, which include a CBC with differential count, and that can help a lot. Like finding thrombocytopenia with small-sized platelets, one should suspect Wiskott-Otrich syndrome. Finding neutropenia, persistent neutropenia, one should suspect congenital neutropenias. Finding a very high leukocytic count in someone with infections, one should suspect leukocyte adhesion defect. The presence of giant granules should raise the suspicion of the presence of Shijiak-Higashi. Lymphopenia raises the suspicion of a T-cell defect, whether a SCID or a combined immune deficiency, and so on. Now, we have a history of someone who has recurrent infections. We start with the laboratory evaluation, as we mentioned, that we will need to do a CBC with differential counts and quantitative immunoglobulin assay. If we find that the patient has low immunoglobulins, hypogammaglobulinemia, this patient requires referral for further evaluation. Also, if we find that there are abnormalities in the peripheral blood that we have just mentioned, the patient needs referral, and there he will need specialized testing in order to identify the exact molecular diagnosis of this patient, and then replacement or hematopoietic stem cell transplantation will. Because the lymphocytic count is so important in diagnosis many of the primary immune deficiencies, we have to give it some time to know how to evaluate lymphopenia. In order to understand this, we must remember that in the first couple of years, the total leukocytic count is high and the absolute lymphocytic count is high, and the average lymphocytic count in an infant and a young child is somewhere above 4,000, 4,500 as an absolute count. So if I find somebody who really is below 3,000, I am very upset about that, and this patient needs very quick evaluation for lymphopenia. This is to contrast with somebody who is above the age of 5 years, when the lymphocytic count drops. The majority of the circulating leukocytes are neutrophil now. They are not lymphocytes, unlike in the young age. So absolute lymphopenia must be interpreted in the function of A. This is a list that you will find in Nelson textbook of pediatrics about the clinical features that lead to a specific diagnosis. However, I don't think this is the best way to think of PIDs. In primary immune deficiency, it's the leading infections and the initial lab tests that will lead to that, but the clinical features that lead to suspicion of immune deficiency, you need to have much more experience in order to be able to interpret. Finally, I will stress that not only we can suspect and diagnose the suspicion of a primary immune deficiency with those simple tests, but also there are more sophisticated tests we just mentioned, and these include the prenatal diagnosis, the neonatal screening, and the carrier detection. Thank you very much.